So CST is across being implemented across all 3 health authorities and with an aim to transform healthcare and improve the safety, quality, and consistency of patient care. So we're going to be focusing on, when we make our designs, to making it work for all 3 health authorities. And we have 4 project drivers. We want to put patient safety first by reducing errors and adverse events, improve quality and consistency of care. We want to reduce the time that clinicians are looking in the charts to improve the experience for patients and the care teams. And we want to draw on the data that we gather from the system for further planning and researching down the line. So for our Richmond SMEs, today we're going to be demonstrating the scheduling workflow for bronchoscopy and endoscopy. And from there, we'd like to see if there's any deviances from what we show you, that's what's done on your site. And then based on that, we can determine whether or not we need to have any design sessions to address any gaps in your workflow. So briefly, this is some of the terminology you might see us refer to. I'll just call it a few. Today, we'll be showing you the scheduling appointment book, which we also call SHAP book for short. The work queue monitor, WQM, is kind of like a virtual fax machine. Perioperative tracking board is the equivalent of our surgical slate. And I believe those are the ones that we'll touch on. So I'll hand it over to Stephanie. She's going to be going over the workflow for us.
Thanks, Whitney. So I'm Stephanie. I'm a business analyst with the surgery and anesthesia design team. So to start, I'm going to go over what the endo and bronch booking will look like in CST Cerner. So prior to date of surgery, the private MOA will fax the booking package and the slate to the bronch endo booking clerk. So we understand what's included. This is the booking form, the consent, and I actually don't know what most stands for.
It's just a code status form.
Thanks, Winnie. And then the clerk will receive that in our equivalent of a fax queue for QM. And they will use that to create the pre-day surgery encounter and also then create the appointment and place the patient on the wait list. When they receive the slate and the patient is been slated for a day of surgery, they will then take the patient off the wait list and book them in for their appointment. Specific to endoscopy, when the appointment is scheduled, EndoPro report generates for provider documentation. Is there any questions about this piece? I will be demoing all of this in the system as well. Okay. In regards to add-on or urgent cases, the workflow is just a little different. So the provider will order the request for endoscopy or bronchoscopy for emergency cases as required. Specifically for ED patients, the provider orders admit to day surgery, which changes the MRP from the ED provider to the endo or bronch provider. They must arrange post-op MRP as well. The bronch and endo clerk will be alerted that a surgery rapid needs to be booked. It's just a different appointment type, which I will demo, and they will schedule the patient in using that appointment type. It just requires a lot less fields to be entered. Any questions about those 2 workflows? Okay, I'm going to demo. Give me 1 second. Stop displaying. Okay, can everyone still see my screen?
Yep, looks good.
Wonderful. Okay, so this is Work Queue Monitor, or WQM for short. This is where you will receive all the booking packages and slates. Each line is the equivalent to like 1 fax. So you can see here, this 1 line is 1 patient's endoscopy booking form and their consent. All the information that will be detailed is just the date and time it was received. You can see there are multiple queues that we can have. So for example, for VGH, they have their endo, all other services. So this is where they would receive booking packages for patients that have surgeries out 2 weeks or longer. But they also have a priority queue, just so they know what's coming in. So this would be more likely for their surgery rapids. To go into the booking form, you just double click it. And then you can toggle through the pages here at the bottom. And this would be what the clerk would use to then book the appointment. I'm going to come back to this and show you how to associate it to the patient's chart once we've created the encounter and put the patient on the request list. So once we have our booking form, the clerk would go to PM office, which is where they're going to create the patient's encounter, which is required for then the appointment to be associated to. There's a bunch of different conversations here on the side, and we use the surgery waitlist conversation for the scheduling workflow. So you just double click it, and then you're going to get the person search window appear, and you would just search for your patient however you want best. So by MRN, PHN, their last name. I'm going to do last name, first name. So here's my patient here. You can see that they have had 3 other encounters created. They've all been discharged. That was really fast. They've all been discharged here. So I'm going to create a new encounter for my patient. I would look up the facility. So right now we don't have the equivalent for Richmond. So we're using Vancouver General Hospital for this demo. And I would select my organization. Sometimes it's slow. Or it's on another screen. You go to the encounter info tab. Everything in yellow and with a red asterisk is required in order to create your encounter. So we're using a pre-day surgery. You can see there can be a pre-inpatient as well. Our medical service. We would place the unit or clinic as a wait list. I never remember what the endo one is called. So we would use VGH endo wait list. You'd put in who the provider is. And then when we're booking onto the request list for the estimated arrival date and time, we usually just put Christmas 2 years from now and the estimated arrival time as noon. And then you would just need to fill out the information on the waitlist info tab as well. So this is coming from the booking package that would be in WorkQM. And those would be all the fields required to create the pre-day surgery encounter. And then I would click complete. And then right now you could print documents, but we don't want to. So that's why it's automatically selected to not. And we'll click OK. And you can see I've created now my pre-day surgery encounter. So after I've created the encounter for the patient, I need to then go to the scheduling appointment book, and I need to create their actual appointment. So this is chat book. You can see that we would have a bookshelf for Richmond Department of Perioperative Services. Each book here is an area. So you can see we have VGH endo, and then there's an area for VGH bronch. And then underneath is the rooms or like resources that the clerk can schedule into. So you can see for VGH endoscopy, they have 4 rooms. We have an add-on room, so those would be for any emergency cases, and also areas that they do endoscopy in at VGH. So specific to their workflow. So I'm going to go to the appointment tab. The appointment type is VGH endoscopy. This is the same for both. Nope, that's so wrong. It's surgery endoscopy. It's the same appointment type for bronchoscopy and endoscopy. Why are you being like this? My location. So the reason why that wasn't working is because my location was set to VGH main OR, and the surgery endoscopy appointment type can't be used in that space. So I just had to update my location. So then I'm going to look for my patient again. That search window is going to come up, and I'm going to select the encounter that I just created. So you would know that because it has the medical service, the date and time, which you just put in, but it also has your provider at the far right as well. You're going to click OK. You put in the provider again. Again, similar to what we saw in PM office, anything that is red with red asterisks and yellow is a required field. So surgical daycare, the priority is always filled out. And then I would put in the diagnosis code that again comes from the booking package. I'm just picking one at random. And then at the bottom here, we have public surgical comments. So this is where the clerk can put in any information that would pull into the slate report, I think is one key piece, and also pulls into perioperative tracking. I will just write something so we can see where that shows up. And then I would put in the order. So if this patient, say, was having a colonoscopy, I would just double click that and add that order. And then in additional procedure details, I can put like verbatim what was on the consent form for the patient. You can also update down here. It's always defaulted to a time depending on the procedure you pick, but you can update and override that depending on what the surgeon requested. So I'll click OK. And now you can see it has moved to the work in progress. And we have these 3 books here. So one for all the resources we're booking into. So we have one for the location, one for the patient, and one for the surgeon. And I'm just going to drag this down to a time that is available. See, my appointment now shows up in yellow. And now all these books that were open in white are in red, which means that all of these resources are available at that time. And I'm going to click confirm. I have a confirmation window pop up and I click OK. So that's it. That's what you would do if you got a booking package and you wanted to book them in right away. They were scheduled. But in the case where you needed to put them on a request list, instead of confirming the appointment, you would click request. And then we have already have a request list automatically selected, which is the VGH surgery wait list. I would click OK. My patient is removed from the work in progress, and they're now on the request list. Is there any questions about that? No? Okay.
Hi, it's Mary. Sorry,
Yes.
just a quick question. So the request list is basically equivalent to wait list, correct?
That's correct. That's correct, Mary.
Yes. Perfect. Okay, thank you. Just wanted to make sure that I got that. Thank you.
Okay. So then I would go back to my booking package, and I want to associate that to my patient. So the first thing I can do here is selecting a patient. So I'm going to get that same patient search window, and I'm going to want to look for the encounter that I created. So I'm just going to select that. You can see here now all the patient information is pulling in. My document type would be an endoscopy booking form. So the cheat code for that is 7501, and it'll pull up as my document type. I'm going to change my status from available to complete. That way it will be removed from the work QM queue. You can also put the provider in. Those are the most important fields to fill out. And then you would just click OK. And then you can see here, that line is no longer there because it's in the patient's, it's associated to the patient's chart. Okay. Now let's say we have received the slate and we need to book the patient in. So we want to take them off our request list or our wait list. How we do that is we go to our appointment inquiry. We go to the request list tab. So my inquiry is to look for surgery case request by queue. I put them on the VGH surgery wait list. My location is surgery. And then I was booking them into VGH endoscopy. And I'm going to click find. And then this is going to show me all the patients that are on the wait list for VGH endo once it loads. Oh, there's not that many. You can sort it by hitting the column at the top. So I can like sort it by patient name or by surgeon. So this is my patient here. And I'm going to right click and I'm going to complete my request. that appointment attribute window comes up. So you can see I can update the order. Say if the surgeon changed, I can update that here, change the time. I'm going to click OK, and now that's going to show up in my work in progress again. And just like before, I'm going to drag and drop this to the time that they're supposed to be scheduled, and I'm going to click confirm. And I'm going to click OK. And now my appointment that was in yellow is blue, and it's confirmed. Any questions about that? Okay, so how this would look on peri-op tracking. So this is our tracking board. For VGH, their pre-op and post-op area is daybed. So the way we designed it is all their bronch and endo cases pull into their daybed board. And it'll show, they'll like, as patients are moving along from pre-op to intra-op to post-op, it will update their status. And when they are done in post-op, they'll drop off the board. So you can see here is my patient. We booked them into the first room here, and it shows the time and estimated stop of their appointment based on what I scheduled. And you can see here, those public scheduling comments where I said would pull into peri-op tracking show up here. It also shows like where your patient is. So right now, our patient is not checked in, so they're still on that endo wait list. But when they are, when that encounter is flipped to an active encounter, so from a pre-day surgery to a day surgery encounter, this will update with their location that they're assigned to. Any questions about the tracking board? The last thing I'm going to show you is how it's a bit different if you have a patient who is being booked for a surgery rapid. So the location is still the same, but as I mentioned during the slides, the appointment type is different. It's a surgery rapid appointment type. And you'll see that like some of the fields are different. So now the priority you have to fill out, it's not selected to like elective. You have to put a pre-op diagnosis, but that like BC diagnosis code is no longer required. And now we have to put in when we were requested to book this as well. So you can see how this scheduling field shifts a little bit depending on the appointment you select. So I would look up the patient that is coming in for surgery rapid. So I'm going to use the same one. You would likely select an inpatient encounter because they would most likely be at the hospital already, and you would click OK. I'm just going to use the same encounter that I had already created. And putting in the surgeon. Say this is an inpatient, and it was an E2. Whatever the pre-op diagnosis is, you would write that there. And then I would put in the time and day that it was requested. And that would be all the required fields. I would click move. Put in the order again. Additional procedure details. And now I would schedule this into an add-on room if we didn't know exactly like when the patient was going to come in and where they would be going. And then that can either be like shifted when we do know, or it's something that the nurse can update in documentation in intra-op. So that would be correct. Oh, so you can see here that my surgeon is booked at that time. So like the time I'm scheduling for it won't work. So you have two options. You can like find a time that works, or you can override. I haven't done that one. I'm just going to find a time that works. I'm on a test account, so I don't think it's set up properly. There we go. So now the surgeon's book is closed, so I can book at that time. And I click OK. And that's the surgery rapid workflow. Any questions? Wonderful. If there's no questions about that, then I will bring up all the questions we have for you. Okay. To clarify, do you share the same clerical resources between bronch and endoscopy?
Hi, it's Mary. Can you guys hear me? Sorry,
Yeah.
I'm just in the car. Okay, perfect. So Richmond is a very unique site because we have an endoscopy clerk that actually doesn't sit in the endoscopy suite. She actually is removed and sitting with OR booking clerk.
Oh, okay.
And then we have a clerk and ambulance that does all.
Sorry, Mary, I think you're cutting out a little bit.
That clerk also does bronchoscopy booking.
Okay, so I think I heard that there is an endo clerk that sits with OR booking, but solely responsible for endoscopy. And then there's a bronch clerk, but she's in a separate area and she also does other workflows. Is that correct?
She does the inpatient endoscopy add-on, so she would schedule the rapid one.
Got it. Okay, that's good to know.
So anything to do with the elective scopes or endoscopy, we have a designated endoscopy clerk that just does the booking like OR booking does.
Okay, that's good to know.
Yeah.
Does anyone have any follow-up questions about that? Nope. Okay. How many printers and fax machines does the clinic have?
So currently we have one printer and fax that sits in the endoscopy clinic, in the endoscopy booking office.
Okay.
That's shared with OR booking.
Okay.
And then we have another printer fax that's in ambulatory care where the endoscopies are done. Normally we don't get booking form fax to be scheduled into ambulatory care, but sometimes so they wouldn't need a queue for elective cases. Does
Okay.
that make sense? Kind of, yeah. And then the inpatient rapid ones, they actually are just given via sticker or MRN or note from the endoscopist to add it on for the day of or the next day.
Or the next day. Okay, that makes sense.
Yeah. Yeah. So there's total two then. So one would be an endoscopy and one in ambulatory care.
Got it. And then for the printer and fax machine that's shared with OR booking, is it all the same fax number that all like surgeons' offices are using, or do you have different?
Yeah.
Okay.
Yeah.
That's good to know.
On the call, she's also an endoscopy clerk. I would say my suggestion would be that we would have separate fax numbers for endoscopy and OR booking.
Yeah.
I don't know if Rana, do you agree with that?
I agree. There should be separate fax lines for both.
Yeah, that would make the most sense. I agree. And then do you want a dedicated fax line for each endo and bronch? Or do you want
I think the bronch would stay in ambulatory care. So that printer could go to that person, and then because it's separate.
Okay.
I think we're still discussing about ambulatory care. What we're gonna do, if we're gonna remain with one generic fax number, or are we gonna split the clinics with different ones? We haven't really decided clearly on that. So, but the bronch would stay in ambulatory care.
Okay, sounds good. So I'll probably send you a follow-up email, Mary, just to help you figure out what's best for that area.
Perfect. That'd be amazing.
No problem. So we'll be getting new numbers. Do you need a single document scanner? So will you need to scan paper into scanner for immediate reference?
Rana?
I don't know what we would be scanning into there unless there would be like the slates would be all online. They wouldn't need to view slates if we scan that in. And there's nothing else that comes separately that we would need to scan.
Okay, so sounds like that's a no. Thank you. Do you share your label printer with any other services?
Yeah, or booking.
Or booking? Okay. And how many labels do you prep for patients now?
I think it's about 20
So-
labels.
Yeah, 20 labels. Yeah.
Okay. And what kind of labels? We have an example. If you can share the screen of what I see the screen of what BGH is doing.
So Mary,
Sorry,
what
can you
what VGH is doing, Mary, is they're doing 10 non-blood specimen labels and 5 patient labels. So that would be the default. So when the encounter is flipped, they would be given a little chartlet and those labels would automatically print. And then if you needed more labels, you can print more. So
that
maybe,
that makes sense.
yeah, so maybe go with what
That's
VGH is using.
I would say yes, because the idea is to go paperless, right? So
Yeah, yeah, you don't want to waste
I
a
guess-
bunch.
no. So I would say let's follow DA. And
Okay.
again, if it's flexible enough to change the amount, maybe we need less. We don't know. We can always update that, right?
Yeah, you could just let us know. Even like during go live, we can come around, and if you're like, we don't need all these labels, we can even adjust it then.
Perfect.
Wonderful. Any follow-up questions for anyone before I go to the next slide? Wonderful. And to confirm, do you do any add-ons or inpatient cases currently?
For
Bronch and endo. It sounds like for endoscopy, yes. Is there any for bronch?
yes,
Yes. Okay. And that's just communicated with a slip of paper that the provider would give the clerk.
correct.
Are there any off-hour cases?
At the moment, we're working on it, but yes, there are long weekend off emergency cases. Yes, there is
Okay. And
for
who,
endoscopy, not for bronchoscopy.
just for endoscopy? And who's responsible for scheduling those?
At the moment, nobody, because usually it happens over the weekend, and then in our ORMIS current scheduler, we can't schedule something that's passed. So we just have to document it with the logging, but we don't actually we don't even document it with the logging. Right now, we don't have a real good process because it's very rare. We don't have as many weekends, but it's starting to ramp up. So we are in the middle of a process.
Okay.
Ideally, we would like to know ahead of time, but I don't know how Cerner works because sometimes we don't have a clerk on the weekend. So if the nurses are able to input it, then it will get captured. But other than that, we won't know till we come in Monday morning.
Mary, how do the nurses know? Is it your endo bronch nurses that come in and do the case with the provider?
Yes, the endo. So right now the process is the provider will give our supervisor a call and say, I need two endo nurses for 4 hours. And then they call in, they bid for the shift. It's overtime right now. And then once whoever's bid on it, they come in and do set 4 hours of scopes. So he may have maybe 3 or 4 or even 5 scopes. And then they get it all done at once in ambulatory.
Yeah. So what I'm thinking is if you don't have a clerk, here's your 2 options. You either find a clerk that can help you out in those cases to schedule them for you that maybe isn't necessarily an endo bronch clerk, but can be resourced to do that work in these cases, or we could train the nurses to do that work. So when they come in, their first job would be to schedule it because it needs to be scheduled to use the applications to clinically document. So someone will have to schedule it. So it's just a question from the site of who's going to do that work. So maybe if you guys take that back and think about the best resource and let us know, then we'll know what we're going to train.
Okay, currently, could you just put in there, I'm thinking we do have an can you just put a comment there, possible or anyway to support that? And then I will then confirm because that would be the best because they will know how to schedule. You just have to train them.
Sounds good. Thank you. And do you do any endo-bronch procedures outside of the endoscopy suite? Are you like in ICU, in the wards, in ED?
Yeah, we do. We do both in ED and ICU,
Okay.
bedside level.
And in those cases, is the nurse the one giving sedation or like the endo-bronch nurse?
No, it's the doctor, the provider only, and then the support of the frontline nurses on the ward, like ICU or ED.
Okay.
That's after hours. If we do it within hours, let's say the patient is vented and it's a Monday to Friday, then a nurse from the GE clinic will go up with the provider, and then we can pre-schedule.
So, sorry, so what I understand is you're saying that the off hours, it's the unit nurse responsibility and the provider does the sedation. And then the unit nurse will provide whatever care is required in their scope. And then if it's within hours, then you send up one of your endobronch nurses to those
Correct.
areas. And then you schedule those ones that are during your Monday to Friday. But are you scheduling the ones that are after hours?
No.
Okay, so just those ones currently. And then
Correct.
do you know, are they doing EndoPro up there? Like, are you wheeling up the cart or anything like that? For after hours and during the regular hours?
Sorry, my phone is crackling up. Can you repeat the question?
Do you wheel up the cart? I'm wondering if you use EndoPro in those areas. Like if you wheel up the cart and use the EndoPro for the ICU and ED areas? Do you know?
Yeah, right now we don't have EndoPro current at Richmond. I know that's coming to us soon, but my assumption would be, yeah, they would use that as a cart. But we do have a portable cart that gets rolled up there for sure.
Okay. Yeah, I'm just thinking about scheduling so that they can use EndoPro. So it sounds like it's going to be not a problem if it's during Monday to Friday. So we'll just have to think about those after hours where maybe if they're going to do EndoPro, how those ones can be scheduled. So we'll take that back and then maybe in the validation session, just run it past you with that workflow.
Okay, perfect. Thank you.
Wonderful. And do you currently book bronchoscopy patients using BC diagnosis codes?
Sorry?
Do you currently book the bronchoscopy patients using the BC diagnosis codes?
No, we don't.
Okay.
And they're not connected to SPR.
They're not connected to SPR? Okay.
And there's no wait list for them.
Okay, so you just receive a slate.
Correct.
Okay.
Sorry, can I ask one more question? When you send your endobronch nurse up during Monday to Friday to those places, ICU, ED, do they provide the sedation or is it still the provider that provides the sedation on those cases?
It's a good question. I would assume they would get the sedation from we would provide it, the nursing would.
The nurses would, okay.
Yeah.
Okay, I think that covers all. And then do you report those procedures, those endo procedures that you do in ICU or ED during the day when you send that nurse up?
Yeah, we do. Yes, we log them. So we do keep tabs on them.
The endo and bronchs for those ones. Okay. You just don't report off of obviously the ones that you don't schedule. So those aren't currently. Okay. Thank you for clarifying. Sorry for all the repeated questions. Just want to make sure I understand.
Okay, just a few more questions. We're almost there. How would you like to name your core locations, if you have an opinion? So we have for daybed, 10 pre-post beds, 10 waiting areas, and 6 bays. Does that seem clear to you, or would you like to change the name?
Sorry.
Can I repeat it? Yeah.
What is VA?
Sorry, it's
Hello?
what is VAs?
What is yeah.
Sami, do you know off the top of your head?
So, sorry, this is John here. VA is Vancouver Acute, so including UBC and VGH.
They have different workflows, like they have a daybed area and stuff. So I don't think it's as applicable to you. So I think the pre-post makes more sense for the wording.
Yeah, I agree because we do get them pre-ready, and then once they're done, the post is their recovery. So I think that's a good idea.
Okay. So maybe instead of calling it day bed, we'll call it pre-post or something, because you don't really have like a day bed unit, right?
No, because the patients are here for 2 hours max, and then they're gone, or even less than that. So yeah, pre and post is good.
Yeah. Or I wonder what LGH calls it, because LGH has the same kind of workflow in which they like have a little pre-post area that's not day bed. Does anyone know what
Yeah,
LGH calls their area?
That would be good if we could find out.
I can
Off the
check
top-
right now.
Okay, thanks, Tommy, because I think that would be a similar flow to you guys. And then you have 3 procedure rooms, is that correct? 3 rooms that you do endos and bronch in?
We have 2 endo rooms and 1 bronch room.
Okay.
Yeah.
So we'll just update that, just to
Yeah.
2 and 1.
Perfect. And then, do endo and bronch share the same procedure rooms at all, or have any overlap?
We try not to. In case of an emergency, we can interverse them, but for now, we have a designated bronch that would never interfere with the GE.
Okay. And how do you want your peri-op tracking board to be set up?
Do the nurses like stay in one room per day? Like, do they stay in the endo room all day, or they go back and forth between endo and bronch rooms?
So there's designated endo nurses for the day, and then the bronch nurse gets split up between another service in amp care. Usually it's a colposcopy SIG or minor surgery. So they have 2 assignments. So they have to switch back and forth. I believe that's what I was told. So one is in the endo, and then if their assignments in the afternoon, they have to switch to the other, whatever system it is.
Yeah, it's about, so they can use the same, it's just about switching for the view of the slate. So you are right.
Got it.
So
Yeah.
they'll use peri-op tracking for their endobronchs, and then they'll use ambulatory organizer to view the other slate. So for endobronchs, are you okay if they're all on the same page? Like endoscopy and bronchoscopy procedures, having them on one slated list? And then, because they would be split out by, well, I guess you could see the procedure and by the room, but, or did you want it split out so that endoscopy is on one tab and bronchoscopies are on a second tab?
I would say split up would be better because just for process wise, I mean, we could always, I think just visually splitting it up, it just makes sense because I don't have the same clerk doing everything at one time.
It's more for the
So
nurse.
it would-
Yeah, it would be more for the nurses because it's at this point, it's more for the nurses to get into the chart, like to look at the slate and get in the chart. So it's like, is it the same nurse who preps and recovers them that goes in the procedure room, or is it a
No.
different nurse?
It's different. It's different. So we have an admitting nurse, and then we have a recovery nurse, and then an endo nurse. So we have 3 nurses
Okay.
taking care of the patient.
And do those recovery and admitting nurses recover and admit both endos and bronchs on the same day? Or are they assigned just to endo?
Yeah, in the same area. So in the
Okay.
same area.
So then you might want to consider putting endo and bronchs together. And just differentiating it by the room and procedure, because then those nurses aren't bouncing around to find the patients. So I think that's what we did, Steph, right? For VGH, they just have one tracking board for endo and bronch, and it's working well for them.
Yeah, for the pre-post,
Okay.
we brought day bed all together.
So that's probably your best bet, is to put endo and bronchs together. If it's the
So
same
can
nurses.
I think that sounds like a good plan, but I'm gonna get one of the endoscopy nurses to watch this slide. And then if their feedback is a little different and they have good rationale why we shouldn't, then I will connect with you guys. But I think that sounds like a plan. And then if I need to adjust it, I'll let you guys know as soon as possible.
Okay, so we'll go with that, and that's what we'll build out, and we'll show you in the validation session too how it works.
Perfect.
And kind of get your feel. Maybe your nurse will be there to kind of give the stamp of approval. Okay.
Perfect.
Okay, so that's what we'll
Wonderful.
go with. So then, Steph, is it one tracking board endobronch pre-post and then one tracking board endobronch intra? Is that what it look like?
We can do it that way.
Or is it just one pre-post intra?
I'm pretty
For
sure
VGH, everything is on
it's
one
the
page.
same. It's all in
Okay.
one.
So
Yeah,
one total. Okay.
yeah. We can separate it out if that's what Mary thinks is best, but VGH currently has it as one.
Yeah, it's probably best.
Yeah. Yeah.
So-
Let's keep it with one, and
Yeah.
then when the validation comes up, then we can just look at it and really see if our site will adapt to it. But I think let's just keep it at one for now.
It's least confusing to be bouncing around and then being like, where did they go? So I think, yeah, it's the less clicks, the better. Okay.
Yeah, you got it.
Wonderful. That's all of our questions, unless anyone has a last minute question from the CST
For the
side.
printer that's in ambulatory care, that's printing for endos and bronchs, you share one printer then for everyone, right?
Yes.
Is it going to be a problem? Is it located in like kind of a nice area by the procedure rooms? Because what's going to happen in the future is when they take pathologies and stuff, a requisition will print a piece of paper and they'll have to grab it. Is it kind of in a good location for that?
There's none in the room for sure. It's centralized in the nursing station, and there's only one, and it would be a bit inconvenient if they have to step out of the scope room. So we may have to look at
It's just a
what that will
thought.
look.
I don't know if you want it in the
Okay.
room. They're not usually in the room, but like usually pretty close, just outside of the room. Sometimes they'll have like a
Yeah.
printer that's more centrally located where the procedures, like outside the procedure room, so that because you'll do a lot of specimens for all those different procedures, so they'll have a rack.
Right. Okay. Good. That's good to understand that flow, because we don't work like that at Richmond. We don't have the luxury to have it outside. But I mean, with the amount of scopes and time, I think that would be something we can explore for sure.
Okay. Yeah. And then if you do get another printer or whatever, you can just let us know, because we'll make sure we route where the stuff prints to whatever printer makes the most sense to you.
Perfect. Sounds good. Sounds good.
I think that was all. And you have a label printer in your ambulatory care area, right? Like I know you said you had one in OR booking, but I'm sure you have one in your ambulatory care area too.
We have two. We have two.
Okay, perfect.
Mhm.
Okay, yeah, I think that all makes sense. And you said you didn't need a single document scanner. I think that makes sense as well. So yeah, I think
Amanda?
that's all the questions. Yeah.
Yeah, hi, this is Rena from the lab, and just a follow-up question to the label printer.
Yeah.
So what is the workflow regarding specimen label getting into the procedure room? Like, how will they go from registration to the providers?
Like how will you get the labels in your hand?
Yeah, how do they get, so for example, when the labels, the non-blood specimen labels would print when the patient is being admitted, if I can call it that. So
Yeah.
how are those labels getting into the procedure room
Yeah.
for them to label the specimens?
Yeah. So when the encounter gets flipped from like the pre-floating encounter to the regular encounter, when they go down to Central Reg, because I think they stop at Central Reg, right, on their way up, then they'll be handed a little chartlet, because it's not going to be paperless. There'll be some paper that's still there. It'll have a face sheet. And then it'll have the labels that were defaulted to print. And then that patient will probably carry them up like they're doing now with their little chartlet and bring it to the front desk. And then that will be given to, I guess, the nurse. Is that kind of how it's happening now? When the patient comes up, they go to Central Reg. Do they give them any papers and armband them, or do you guys do that up there?
We lost Mary.
Oh.
Yeah.
I think it was Rana anyways. But
Oh yeah, so I'm a CIS with the lab, so I wouldn't be familiar with
oh, sorry, I
current
thought you're from the
state.
site.
No,
Sorry,
sorry, I should have
Rana.
introduced. No, I should have introduced myself. I'm worried about future state.
Oh no, yeah, no, it's totally fine. Basically when they flip the encounter, the labels will automatically print, or they can print more labels. manually if they ran out of labels. But usually the patient will be given a little chartlet and they'll walk it up to wherever the unit is, like in the wait room, and give it to the front desk, and the front desk will give it to the nurse or whatever. And
Okay,
that's how they
perfect.
get in the room.
Perfect. Thank you so much.
Yeah, no worries.
The site have any questions for us?
No, but I'm just mindful that Mary did drop, so maybe I'll have her reach out if there's any follow-up from her end. And I think
Sounds
that
good.
last question, if you can just send it over to Mary in just a quick email, that'll be appreciated.
We can do that. Thanks, Jonathan.
Thank you.
Okay, and then just quickly going over our upcoming sessions, we have a provider session scheduled for the 31st. We will discuss, because we have a lot coming up back to back. We also have the clinical documentation session on August 1st and the scheduling on tentatively scheduled for August 2nd. Oh, here's Mary. So we might postpone one of them just because I imagine that is a lot for the site to
And
do back to back.
it's is there these are all just related towards just the bronchs and the endoscopy?
Correct. Yeah.
These four, eh? Okay.
Mhm.
It would be great if we can space it out a little bit, or we can, or the other way is we can combine it all within like the clinical documentation, validation, and the scheduling piece. If we can
Mhm.
join it all together, I'm sure we'll be more like focused and ready, and they'll fit better for our schedule. But otherwise, if you do need all of that time, then I can work out the scheduling piece. But it'll be
Okay.
great if we can space it out just a little bit more.
Sounds good. We'll talk as a team and then figure out what we can do, and we'll get back to you about that, Jonathan.
For
Yeah,
sure.
but
Thank you, Stephanie. Mhm.
it makes sense to put the
Hi, it's
scheduling with the
Mary.
clinical.
For sure. Yeah. If it makes sense and if this is the standard word. Hey, Mary. Hello.
Sorry, I'm so sorry. My phone disconnected and shut everything off. So
No,
I
you're good.
apologize if I
All
screwed
good.
you up. Okay.
Okay. So
Okay,
Mary,
did you
we're
guys get the answer about the label? Were you guys able to get the label answer, or you guys are good, or?
Yeah, no, I
It's-
think it's totally fine.
so Mary,
Perfect,
they're
okay,
going to
sorry.
reach out if they have any outstanding questions. And likewise, if you have anything, then we can reach out to them. We're just planning about the
Okay.
future engagements now, and I can take that away. Thanks,
Okay,
Mary.
awesome.
Wonderful.
Thank you.
And yeah, like so in response to the different sessions that needs to be booked, that's completely fine with us, right? If there's a certain workflow in different groups, I imagine that would be involved in this. We'll just we'll figure out something between
Okay.
maybe yourself, Winnie, and me.
Sounds good. Wonderful. Well, that is everything we needed to go over today. So thank you so much, everyone, for your time. I'll give you some time back. Enjoy the rest of your afternoon.
Thank you. Have a
Have a
good
good
night.
everybody.
weekend,
Bye.
everyone. Take care.
Thanks.
Bye.
Thank you.